So my name is Matt Eby. I'm a regional manager of support services for leukemia and blood cancer. I'm actually based in Christchurch, so hello to you. But big welcome to have you join us with our next installment with our winter-spring webinar series. I'm actually joined by Professor Andrew Spencer. And just want to do a little bit of an intro before we get him set up here. He's actually the head of the Malignant Haematology and Stem Cell Transplantation Service at the Alfred Hospital, professor of hematology at Monash University, and head of the Myeloma Research Group. This is all in Melbourne, Australia. He had extensive experience in academic, pharma, preclinical, and clinical collaborations in developmental therapeutics and the design and implementation of investigator-initiated trials in multiple myeloma. He's had over 210 peer-reviewed publications with over 16,000 citations and holds 5 international patents in multiple myeloma therapeutics. Since 2015, he's been an invited speaker at 48 international meetings on genomics, therapeutics, and disease monitoring in multiple myeloma. He's been serving on the scientific advisory boards for the International Myeloma Foundation and a part of the International Myeloma Working Group. So yeah, he's actually been chairing the Myeloma and Related Diseases Registry and the Asia Pacific Related Disease Registry and the associated M1000 liquid biopsy biobank. So he's helped to establish the Australasian Myeloma Research Consortium in 2016 and sits on a steering committee for the Global Myeloma Registry Initiative Insight. So thanks for bearing with me as I could get those words out of my mouth. And Andrew, a big welcome to you. And I know we've kind of titled it Treating Myeloma in 2020. Absolute pleasure to have you on with our webinar. I'll say one thing before I turn it over. For those of you at home or wherever you're viewing, if you kind of look, you have a chance to, there's a Q&A. So some of you are getting really good at this. You just can type in, punch right in your questions, even throughout the talk. And then, yeah, we'll have a chance when he's finished to get some of these questions answered. So thanks for that. Thanks for participating. So with that, Andrew, I'll kick it over to you, but thank you again for coming onto this webinar.
Thank you. I just have to sort out this. Won't take me a moment. Here we go. Okay, so thank you very much for that very kind introduction. I'll give a very brief introduction about myeloma and I think some of the key challenges we face, and then I'll touch upon a few areas in relation to treating myeloma. So not just about drugs, but some of the paradigms that are emerging that I think we need to be thinking about more and more. So you all know that myeloma is a complex disease clinically. If you look at the graphs down the bottom there, you can see that the rate of deaths from myeloma have not gone down despite the introduction of IMiDs and proteasome inhibitors, indicating the ongoing unmet need for new therapies. The major challenge with myeloma is the understanding the genetics and epigenetics behind it. This is a sort of dumbed down picture that I stole from Leif Bergsagel, where we like to think of myeloma as 50% being hyperdiploid with chromosomal amplifications and 50% non-hyperdiploid, good and bad in terms of prognosis, but that really oversimplifies the situation to a great degree. Follows a responding, relapsing clinical course, and we have in our minds that people get line after line of therapy, but this is not necessarily so in the real world. And I think just this data from the registry, so this is 600 or so patients who died of their disease while being watched on the registry. And I think you can see what I'm on about here is that whilst this is clearly biased because these patients are deceased, a large proportion of patients don't get beyond 1 or 2 lines of therapy, and some elderly patients don't get treated at all. So this really argues for the introduction of more effective therapies early in treatment rather than being fobbed off to later lines of relapse. The major problem with progressive disease is the spatial and genetic heterogeneity that emerges, meaning that there's quite a diverse genetic background as patients go through these remitting, relapsing phases of disease. And we select for increasingly resistant disease, and that's why people die from myeloma, and it remains incurable. We highlighted this a number of years ago. We've been very much into liquid biopsy work, and if you just look at this simple bar graph, if you look over on your right, these are newly diagnosed patients where we looked at plasma and marrow with a very high sensitivity targeted sequencing approach. And there's only a couple of these newly diagnosed patients where there are mutations in the plasma that are not in the marrow. But then if you look at this relapse group, you can see it's an explosion in the number of mutations and the number of mutations which are not picked up by the marrow biopsy. So just talking to the spatial heterogeneity. And even within areas of localized disease, this is an unfortunate patient of ours who developed a plasmacytoma. We took 3 biopsies from this plasmacytoma, and in fact, we could show that there was heterogeneity even within the same lesion. So it represents a massive challenge, and the one-size-fits-all approach which we currently have really does not address this, and I'm hoping we can start getting some personalization of treatment as we move forward with some of these newer classes of drugs which are emerging. So I'm going to touch upon these topics. I think they're all quite pertinent. At the end, if there's time available, I'll whip through a couple of recent studies that have been published, which I think are relevant to us and interesting. So first, I'll talk about risk stratification. So you'd all be familiar with the revised ISS. This was published a number of years ago, and clearly is able to define 3 groups with differing prognoses. And it's been widely adopted and accepted as a useful tool. There are certain caveats with respect to this, I think, that people perhaps don't realize. Clearly, this was all based on clinical trial patients, not real-world patients. And in fact, 1/3 of the patients which were going to be included in this couldn't be because they lacked the available data. So they didn't have FISH or they didn't have an LDH. And this is echoed in the real world, where the registry shows that only about half of patients actually have cytogenetic information. So the utility of these models is limited. There was a paper also out 5 years ago which looked at various models for prognostication, including the ISS, expression profiling, and FISH. Very comprehensive study. And the investigators looked at a range of models. They looked at single models, and then they used combinations of models. And the single model which had the best capability of predicting outcome was this EMC92. So this is gene expression profiling platform that was spun out of the Hobon clinical trials. Looks at 92 genes. So it's a particular algorithm which interprets Naphametrics chip analysis. And in fact, if you look down here, the combination of the EMC92 and ISS was the winner in terms of all these different prognostic models which are available. And the EMC92 has been looked at in a range of different data sets. You can see here, the red line is EMC92 high risk, blue standard risk, and there's a massive difference in outcome across both newly diagnosed and relapsed patient populations. So when we look at the combination of these, I think you should focus on these pictures up here. When we combine the EMC92 with ISS, the red line is the EMC92 high risk. But then if you split up the standard risk based on ISS, you can see, importantly, there's a population of patients here, which is about 1/3 of the patients, which you can define as having an extremely good outcome. So you could argue that in these patients, a less intensive, more affordable, less toxic approach is appropriate. Conversely, for these high-risk patients, you can see the median overall survival is only about 2 years. And clearly, this is an area of ongoing unmet need in terms of the need for more effective strategies for treatment of these patients. And this is more powerful than the other models. So we've been doing this in the context of clinical trials for a number of years. And for the past 12 months, we've actually incorporated this into our clinical practice. looking at patients up to the age of 75 at their diagnostic marrows. And this is what the results look like. And I just want to highlight something of importance here. So this patient actually does not have high-risk disease, but you can see that they had a translocation involving MAF, and they in fact had deletion of 17p, which would be expected to be, defining a person with poor risk disease. But I think it's not necessarily so, and that's consistent with this paper, which was recently published from the Myeloma Genome Project in the US, where next generation sequencing on nearly 800 patients was looked at, and the prognosis of these patients was looked at. And what these investigators showed was that, for example, for TP53, you needed biallelic loss of this to actually get a bad prognosis, and this is the blue line here. So patients just with 17p deletion were not in this poor risk group. And what this is telling us is that really you need a combinatorial approach. You need to look at a group of different lesions to define high-risk populations. Unfortunately, in this particular study, there was no incorporation of LDH, which has always been an important marker, but nevertheless, it's a very interesting study. And the other limitation is that these double-hit patients represent only about 6% of patients. So in terms of its clinical applicability, it's limited because there's still plenty of other patients who do poorly who don't have this particular lesion. So in a poor man's world, we've looked at high risk in a different way. We've been looking at functional high risk disease using data from the registry, so real world data. And we know that the registry now is very representative of the treatment of myeloma in Australia and New Zealand. You can see the sites here, great contribution from the New Zealand sites. We've now actually rolled the registry out into the APAC region, got nearly 500 patients enrolled in a number of East Asian countries. And in this particular study, we looked at over 1,500 patients, and we looked at the duration of response and the depth of response. And for the purposes of this talk, I'll just look at the duration of response. And we defined early progressors as those patients who progress within 12 months of commencing first-line therapy, and late progressors as those who progressed more than 12 months after the institution of first-line therapy. And the results were quite striking. So here we've got the PFS curve. Remember, these are all newly diagnosed patients. PFS2, so this is now the time to the second relapse, and overall survival for these early progressors versus late progressors. And what you can see is the profound impact on survival that this early progression phenotype exhibits. I've tabulated those data down here, and if we look at the early progression patients, they represent nearly a quarter of the patients in this particular cohort. They've got a very short first remission. They're essentially not salvageable in any meaningful way, and they've got a median survival, overall survival, only 17 months. Interestingly, the patients who actually progress on their first-line therapy without responding do better. So this tells you that these are actually quite diverse in terms of the underlying drivers of disease progression and disease response to therapy. And these patients, I think, clearly represent another group where we need to work harder. When we tried to identify what might predict for these, the usual suspects came up. So these scoring systems were more represented in the early progressors. But in fact, if you look, for example, for the ISS3, half of the early progressors were ISS3 and half weren't. So these scoring systems don't predict who's going to get this early progression. Moreover, if we looked at single fish lesions, these were not predictive at all, which is consistent with this paper, because if you look at these lesions here, they were not good predictors of outcome compared to these other models. And finally, when we went back to the Walker paper, the one I mentioned from the Myeloma Genome Project, they actually looked at patients with early progression, and they looked at a range of different lesions from the sequencing data. And in fact, there was no particular lesion which stood out as being a predictor for this early progression. So I think this represents a challenge, not only therapeutically, but understanding what's driving this early progression after response in these patients. Looking at first-line therapy, if we look at real-world data, this is from the Insight Registry. It's the best we've got really from a global perspective, although it's not all that representative globally. You can see here we've got US, European, Latin American, and a single East Asian representation. And this is first-line therapy in transplant-eligible and ineligible patients. And what you can see is there's quite marked variation depending on what jurisdiction you're in. If you live in the US, you know, VRD is a standard of care, but actually it's not a standard of care anywhere else. And I'll show you why it's not. And of course, you've got increased utilization of thalidomide in other jurisdictions because of the cost of the subsequent IMiDs that are available. But the takeaway was that in 50% or so of patients, whether they're transplant eligible or not, bortezomib really is the backbone for first-line therapy. We'll look at the registry. We'll look at January 2019 over here. These are newly diagnosed patients, large number of patients. 85% were getting bortezomib-based induction, vanishingly small numbers of IMiD-based induction. We've just looked again last month, a consistent number of patients getting bortezomib, but we're seeing a shift here. And this is because Revlimid and dexamethasone has now been reimbursed for non-transplant eligible Australian patients. You can see an accumulation of patients getting that at the expense of thalidomide, which is now dropping off. But if we look at patients who are non-transplant eligible and transplant eligible, 85% of non-transplant eligible patients in Australia and New Zealand get bortezomib-based induction. So I think you would say that in our jurisdiction, this is a standard of care. And the response rate to this is high. Response rates are in the 80% plus range. The utilization of RevDex was based on the first trial, and Celgene have always promoted the continuous therapy model. So PFS was unequivocally improved with Lendex in a continuous fashion, but no overall survival benefit. But nevertheless, this data has informed the reimbursement and use of RevDex in about half a dozen or so countries around the world. So again, RD may be put across as a standard of care, but if you look in a global fashion, it's actually not because of the cost implications. Is RD better than other things in elderly patients? There'll never be a comparative study done. So we get these sorts of network meta-analyses done. You can see where indirectly RD is compared to a whole range of other options in this space, which have been trialed. And not surprisingly, based on the driver of this particular publication, RD comes across as being the superior agent, both in terms of overall survival and progression-free survival compared to this range of other options. I might add that we've had a quick look at the registry data now with the uptake of RD in Australia, and we would not agree with this data in the real world. We don't think there's much difference between bortezomib-based therapies and RD in the non-transplant population. What about VRD as an alleged standard of care? There really isn't any good randomized data that I can find. It certainly is an attractive option when you look at the different agents involved. There's this sort of data from the Mayo, which was Mayo data combined with one of the US oncology networks, looking at VCD and VRD. This is a mixture of people that did and did not get transplantation, as is usual in US studies. Response rates were basically the same. The most recent data I can see was at the RMW last year at the workshop. This is from India. So this was a probably underpowered randomized study looking at VRD and VCD as induction. What it did demonstrate was a higher response rate with VRD compared to VCD. There was no comment about outcomes post-transplant. And this mirrors some data from the IMF from a number of years ago where they saw a high response rate with VTD versus VCD, but no difference post-transplant. Now the SWOG paper, this is probably one of the most widely quoted papers for the validation of VRD in the non-transplant population. And I sometimes despair at that. If you look at this paper in detail, it was a really well-designed study of VRD versus RD, but the median age of the population on this study was only 64 years. So these were largely patients who in a non-US context would have all been autografted. So I don't know how you interpret this data to justify clinical practice outside of the US. And importantly, in the follow-up study, or the follow-up or longer-term analysis, which has just been published, in patients over 65, there was no survival advantage to VRD over RD. And I think this recapitulates what the Italians have described, that in elderly patients, use of triplets and more complex regimens really leads to early discontinuations and toxicity leading to dose reductions, which then impacts on outcome. So certainly in our jurisdiction, I'm still a bit of a fan of bortezomib or RD-based induction in the elderly, even though I can access VRD. And it's this uncertainty around what to do in these patients. It's informed the design of the AMARC 1901 ALLG MM20 trial, which it now looks like we can get New Zealand sites involved with if there's interest. So this is a study that's going to look at different schedules and doses of therapies in elderly patients based on strata defined by their frailty. This is an MRFF funded study, not an industry study. And we're just trying to roll this out. Now, it's been a major challenge in the context of COVID, trying to get sites open, but we're hoping that we will be able to complete this study, because I think it will answer some very important questions about how we should be treating our elderly patients. Maintenance therapy. So lenalidomide is the standard of care in this context. There was the McCarthy meta-analysis, which was published a couple of years ago. This was a subsequent meta-analysis from the Italians, which actually included a lot more studies. And interestingly, included the Myeloma 11 data before the Myeloma 11 study was actually published. I'm not sure how they managed to swing that one, but it's important that it was included because this is the single biggest study done to date looking at lenalidomide maintenance therapy. And this is the design of the particular study. And you can see they included a range of different trials with lenalidomide, thalidomide, and various other options with bortezomib and even interferon. And what they showed in looking at PFS and overall survival, now with over 5,000 patients, with PFS, the actual winner was len with pred. And you'll remember way back when we did the MM6 study, we did thal with alternate day pred, which seemed to be reasonably well tolerated. But when it came to overall survival, the winner just by a hair was lenalidomide. Although for the purists, this wasn't statistically significant, but nevertheless, it did look to be the best agent in terms of overall survival. And the conclusions of the authors were that probably lenalidomide was the way to go as a single agent if you had it available for maintenance therapy. Now, the MRC study was subsequently published, and this is the paper here. And you can see a very significant improvement in PFS, but no improvement in overall survival, which was mirroring the IFM experience. And when they looked at the forest plot, really all groups appeared to benefit from the use of lenalidomide. And again, I'm going to show something interesting here. So they looked at these various high-risk fish lesions, which you can see here, 414, 14, 16, 17p and such. And generally, len was favorable in all of those groups. But they've now published another paper just very recently where they actually looked at that EMC or Sky92 signature in this study. And in this large UK-based study, about 20% of the patients had a high-risk signature. And when they looked at those patients in the terms of lenalidomide maintenance, they found something quite striking. So if you look here at progression-free survival, this is the len maintenance group with the standard risk signature. This is the no len maintenance group with the standard risk signature. So you can see in the standard risk patients a quite marked impact on progression-free survival. But these two lines represent patients with and without lenalidomide maintenance who had a high-risk signature. So this is 20% of patients. So you can see that patients with a high-risk signature actually derive no benefit whatsoever from lenalidomide maintenance. And this clearly has toxicity and cost implications and suggests again that there needs to be some stratification and alternative therapies explored in people with high-risk disease. And when you look at the overall survival, again, you can see that these curves are almost superimposable. Now, MRD, this really is a hot topic. There's a multitude of publications are emerging. It's being leveraged very heavily by pharma as a tool to get early drug approvals. And you can see where they're coming from. So if they can get a readout from a clinical trial in 18 months rather than 5 years, it affects the bottom line. It's also important from a patient perspective that if you get early drug approvals, people potentially could get access to drugs earlier. So it's an area where there's a lot of work, but there's also a lot of uncertainty, I think. And I'll just walk you through some of the data here. So we've known for a very long time that depth of response, if you look at groups of patients, correlates with outcome. I think the IFM in 1997 were the first collaborative group to demonstrate that achieving a CR or VGPR correlated with improved overall survival versus those with less than that depth of response. Now, subsequently, there have been a whole plethora of studies as new agents have emerged looking at depth of response, and they've all told the same story, that the deeper the response, collectively speaking, there are always exceptions to this, the better you'll do. So this was some data from 7 years ago now from the Mayo Clinic, when stringent CR criteria were applied to their experience. And you can see, looking at overall survival, patients with stringent CR had a better outcome than those with CR or those who had immunofixation positivity but otherwise looked to be in CR. So just a recapitulation of, almost 20 years of data showing depth of response correlates with outcome. And that's driven, a sequence of different definitions of response, culminating the IMWG introducing some minimal residual disease criteria in 2016, when we'd now moved beyond serological parameters for the definition of disease response. And there was a consensus paper published not long after that, where these are the criteria which were accepted. So we had flow negative MRD, we had next generation sequencing based MRD, and it was agreed that 1 in 10 to the 5th was the threshold of sensitivity required. And also added into this mix was imaging. And I might point out that nearly all of the trials that have been published looking at MRD, bar perhaps one IFM study, have not systematically included imaging. So they've relied either on flow cytometry, Euroflow, which I'll touch upon, or next generation sequencing. But realistically, we're supposed to have one of these and imaging negativity. So the sequencing approach has been driven largely by biotech companies in the US, with Adaptive being the leaders in the field, and this has now got FDA approval. This is based on a PCR methodology, a consensus PCR methodology, where the clones within a patient with myeloma will have a unique complementarity determining region in the clonal plasma cells. And this is picked up, first of all, with a consensus PCR approach, sequenced, and then that's the target for subsequent sequencing analyses. So with the sequencing, you need a baseline sample to identify your unique complementarity determining region sequence. That's present at diagnosis, and then that's what you look for at subsequent time points. Now, there's always been a bit of, mine's bigger than yours in this space, and there's a lot of advocates for sequencing, largely in the US, but the French tend to put it about a bit as well in this space. And there are certainly some advantages in this approach, in that it's probably more sensitive than Euroflow, and we'll touch upon that in a moment. But there are cost limitations, access limitations, and also you need this baseline sample. So the Euroflow platform was developed by the Spaniards, and this was bankrolled by the IMF, very generously bankrolled by the IMF. This is a 2-tube approach. These are the markers here. And there's a multitude of publications now have validated the use of this in a range of clinical trials. And there's even a software which allows automated analysis, this Infinisight software. And we adopted using Euroflow in 2014. So this is a picture from our lab. It's a very elegant platform because not only does it allow you to detect MRD, it actually tells you about the different clones that are present and the different markers that they're expressing, because there's evidence emerging that the expression of some or all of these markers, in fact, may have prognostic implications. So there's the Euroflow platform, and then there's the NGS platform. Now, this is an important bit of data. So this was a collaborative study from the Europeans, HOVON and IFM, asking a question about DARA VTD versus VTD. And, you know, the expectation would be that the inclusion of DARA remarkably improved outcome, which it did. But for the perspective we're looking at is that they did MRD analyses at 2 time points in this study. Now, all of the patients, or the intention was all of the patients would have Euroflow with the standardized approach that I've described to you. But in a subset of patients where the material was available, they also had next generation sequencing done with that clonoSEQ platform. So this was the first study that really allowed comparison of these two platforms in a sequential fashion in a trial population. And to cut a long story short, if you look here at this box I've got highlighted in yellow, so these are people at MRD, but also in CR. I'm not going to get into the issue of MRD, which is not in CR, because it really is a contradiction in terms. But you can see the concordance here, the observed agreement between both flow and sequencing was very high. And so this is an important observation that probably you can use either of these platforms as a biomarker, because that's what it is. It's a biomarker which you can use to predict outcome. And if we look here at this particular Kaplan-Meier, just to reiterate that DARA VTD, VTD, these are MRD CR patients, and you can see that irrespective of the treatment, these lines are superimposable. So MRD negativity, a powerful prognostic factor, and probably you're valid in using either strategy depending where you live and what you can afford. Now, because there's been some uncertainty about how these things are reported, there's now a consensus paper about harmonizing the reporting of MRD. This has just been accepted by Leukaemia, and it's all about making sure that you report the results in intention to treat populations and in patients who are in CR, because there's been a bit of grayness around the reporting. And this is an attempt to make sure that you can compare across different studies, because you're talking about the same thing. Now, what about sequential MRD? The MRC11 trial has been an absolute bonanza in terms of data emerging from it. And they looked at MRD in the context of this trial. I won't go into the trial's design because it's very complex, but there are just some key data with respect to MRD. So if you just bear with me, I will talk about this. This is looking at maintenance lenalidomide in this study. And what we've got is we've got the impact of maintenance, but also MRD negativity. So this yellow line are patients that got maintenance who were MRD negative. The green line is len who are MRD positive. So you can see the impact of being MRD negative in the context of getting lenalidomide. The red and the blue lines are patients who are MRD positive and negative, not getting any maintenance. So you can see that by far and away, the group with MRD positivity and no maintenance did the worst. But there's benefit to the len in this context, whether you're MRD positive or negative. And it was quite significant statistically and clinically relevant. But perhaps one of the more interesting observations was when they did the repeat MRD analysis. So what they showed was that in patients who got MRD repeated, who were on maintenance therapy, there was a transition to negativity in those getting lenalidomide, but not seen in people that didn't get lenalidomide. Moreover, those who were MRD positive had a lower tumor burden on len than no len. And probably the most interesting aspect was that if you were MRD positive, went on to lenalidomide, converted to negativity, this is the blue line, your outcome was probably quite similar to people who are MRD negative initially. So it just shows there's a consolidative effect from maintenance strategy, which can benefit patients who initially have not achieved MRD negativity. This is some very old data from our site where we looked at Euroflow in allograft patients, and it highlights one of the limitations and talks to the issue around spatial heterogeneity. So this PET scan on the right here is a patient who's got these atypically distributed plasmacytomas. This person was repeatedly MRD negative on Euroflow. because at the site of biopsy, they were MRD negative, but they had these lesions. And I think this is one of the challenges that we face, that single site bone marrow biopsy, I think in the future is not going to be adequate for assessing patients. And we've had innumerable patients now with this sort of pattern, both with and without allografting, where we can show that MRD negativity on bone marrow biopsy doesn't necessarily rule out the presence of disease. One of the things I think is interesting that's coming along, which might help to mitigate against this, is mass spectrometry. So we've been working with Binding Site looking at this. This is a process where the proteins of interest are pulled out with beads and then subject to mass spectrometry. And we use the ALG MM17 trial as a platform for this because we were doing paired mass spec analyses and Euroflow in these patients with poor risk myeloma who are being salvaged with a KTD approach. And this was presented at ASH. And there are just two quick takeaways from this. If you look at this bar graph here, so these are patients now who are about 6 or 7 months post-transplant. And we can see that the remission rate with the mass spec is actually lower than the MRD negativity rate, because the mass spec is actually, I think, giving you a more holistic picture than the bone marrow biopsy. So you'd have to suspect that a number of these MRD negative patients are false negatives, and with subsequent follow-up, we may be able to demonstrate that. Importantly, when we compared the mass spec to standard serological analysis, there was a number of patients who were negative on SPEP who remained positive on the mass spec, because it's actually a couple of orders of magnitude more sensitive. And I'd be surprised if this technology doesn't start to become more widely used in the next 5 to 10 years and probably replace what we do now in terms of paraprotein light chain estimation. Now, I'm just going to touch upon a couple of new studies, which may or may not in due course be relevant to how we practice, because there's always the challenges of cost. And I picked 3 studies quite deliberately. The first one I picked is this study, the endurance study, looking at KRD versus VRD. So we hear that VRD is a standard of care, and amazingly, the PBAC in Australia have now reimbursed VRD. I say amazingly because, you know, there are certain therapeutics where there's a massive quantity of data supporting their availability, well, making them available to patients that we still can't use, and yet we've got VRD reimbursed. So I looked at this study because, you know, we're now hearing stories, well, no, we should be using KRD. It's going to be better than VRD. And we all know the challenges around the use of carfilzomib. So this was a ECOG study, so it was an industry-driven study, and it looked at VRD versus KRD. And there were 2 endpoints. There was PFS subsequent to the first randomization to KRD versus VRD. And then there was an overall survival question looking at fixed duration versus continuous maintenance, because there's been this French-US argy-bargy. The French insist you should only go out to 2 years because they're concerned about secondary malignancies. The Americans say, no, you should go all the way to progression. So this is still to be read out. This will take quite some time to read out. But the PFS data was presented at ASCO. Now, as is not uncommon in some of the studies from the US, patient retention is a problem. So this was a big study. You've got to give it to the investigators that they did very well. But a lot of patients came off study for a variety of reasons. And in fact, I spoke to Shaji Kumar about this study because I was a bit surprised about the outcome. And he said they were surprised too, and you'll see why in a minute. And he actually touched upon an issue which really doesn't affect us when we do clinical trials, in that he was saying that the K, or the Kyprolis, was being supplied by Amgen, whereas the bortezomib was commercially available to patients. So patients were paying for the bortezomib by their insurers, and that led to a reduced duration of treatment on Velcade and people skipping off to other therapies. So I think you need to put these trials in context. The other thing was that only a minority of these patients, and the median age was in the low 60s, only a minority went on to transplantation, which is not what we'd see in our jurisdictions. So again, you need to keep that in mind when you look at the data. They also had a policy of not putting high-risk patients on the study, but their definition of high risk was the Mayo definition, which I don't think most people agree with at this present time. But nevertheless, those factors notwithstanding, what was surprising was that there was absolutely not a shred of difference between outcome at that first readout at PFS. So if you look at the Kaplan-Meiers here, the median PFS with VRD was 34 months. Median PFS with KRD was 34 months. In fact, if anything, the curves are starting to separate with longer follow-up in favor of VRD. So this was not the expected result. And importantly, in older patients, I think unequivocally VRD was the better combination, probably because of the tolerability issue. And in fact, in patients who got transplantation, keeping in mind that there was a very limited number of patients, again, no difference in outcome if you got VRD or KRD before you transplant. So I think giving some assurance to us all that using bortezomib frontline like this is quite a reasonable way to go. When they looked at non-hematological toxicities, there was no surprise. These are grade 3 or more, more neuropathy with VRD, but then a range of sort of vascular endothelial problems with KRD, which we recognize as being a problem with kyprolis, and which I don't think are clearly understood yet, the etiology. We'll look at this table here. There was a statistically significant increase in grade 3 to 5 or 4 to 5 toxicities with KRD. And this may underline the difference in outcome in terms of PFS, because I think probably, when you sum it all up, K is probably a more active agent than bortezomib. So the conclusions were that, I've not shown this, but KRD had a response rate, but there was no difference in PFS. So the VRD, from the American perspective, remains a standard of care. This study is interesting. There's been a lot of daratumumab papers published of late, so I thought we'd look at isatuximab, which is an alternative CD38 targeting antibody. This is a similar study to the Candor study, which Amgen did, where they looked at Dara, carfilzomib dex versus carfilzomib dex. And in fact, just in the past week, the FDA has approved Dara carfilzomib dex for patients with 1 to 3 prior lines in relapsed disease. So this is an alternative approach, and I thought it was of interest. It was an interesting design. They had a 3-to-2 randomization. The KD was very standard, based on the Endeavour trial, 56 per meter squared, and all they did was add in the isatuximab with the standard isatuximab dosing. The patient population was a reasonably heavily treated population, a median of 2 prior lines of therapy, and quite a significant number of patients in both arms were refractory to lenalidomide and proteasome inhibitors, which we know is an adverse factor when we're looking at these relapse studies. And in fact, 50 to 60% of patients were actually refractory to their last line of therapy, so progressing on their last line of therapy. So these weren't good players by anybody's estimation. And when we look at the primary endpoint is PFS, we can see that there was a substantial improvement with adding the antibody into carfilzomib dex. And I don't think anyone is particularly surprised by this. And whilst it's dangerous to compare across studies, this actually looks to be better than what was seen in the Candor trial with Dara-KD. But I think you'd really need to look at the breakdown of the patients in the 2 trials. But nevertheless, a very, I think, significant improvement in outcome, and some evidence, hopefully over time, that maybe you might see a bit of plateauing here because of a maintenance effect from the ongoing use of the monoclonal antibody. Safety summary, I'll highlight 2 things. First, there's a respiratory infectious signal that's very evident in the Dara studies that I've been involved in. These tend to be non-bacterial infections. And I think these CD38 antibodies are probably more suppressive than was first thought. You often see quite profound reductions in both light chain isotypes, which suggests to me that plasma cells are really being hammered by these antibodies. And if you look at these AE terms here, respiratory tract infection, pneumonia, bronchitis, they're more common in the ISA-KD than in the KD population, both all grades and grade 3 or 4. So this is recapitulating what was seen in the daratumumab studies. And the other important thing is neutropenia. You can see substantially more grade 3 and 4 neutropenia with adding in the isatuximab. Again, recapitulating what was seen in the DARA studies combined with bortezomib. Conversely, in the dara-revlimid ones, it was more of a thrombocytopenia problem that was being seen. But here you can see that this is quite important. So the conclusions here was that adding isatuximab to KD was clearly advantageous in terms of PFS, with almost a 50% reduction in progression or death. I didn't show you the MRD negativity rate, but again, it was substantially better with adding in isatuximab. And the safety profile, they said, was manageable, and I think they're probably right, and not any different from what we see with DARA-KD. So last thing I'll present is something which I think is really very exciting. We hear lots and lots about immunotherapies and CAR T cells, and really a lot of hype in that space. But in the background, there are some other very interesting compounds coming along. And this is a first in human study of one of these compounds, CC92480 or CC480, which is from the Celgene pipeline, now gobbled up by BMS. So CC480 is what's called the CELMoD, so cereblon ligand modifying drug. But these are just IMiDs. They've rebranded these agents, so they're structurally similar to pomalidomide and lenalidomide, but certainly in vitro are profoundly more active. And we've got actually a collaboration going on, preclinical collaboration with the San Diego Celgene people, looking at 480 and 220. I would be able to tell you from personal experience that they have a higher level of activity and work quite nicely in cell line models of lenalidomide and pomalidomide resistant myeloma. So I think they hold great promise. So the results from this study were eagerly anticipated. It was a complicated study. There was a continuous schedule and then this intensive 3-day schedule, because really it wasn't known how to dose these things because of their more profound activity than the usual IMiDs. But to cut a long story short, it turned out that it's the same old story. 21 days out of 28 is the way to go with CC480, and the dose is 1 milligram a day. So this is the dose which will be taken forward in an expansion study, which some centres in Australia, I don't know about New Zealand, but some centres in Australia are participating in this study. When we look at the population of patients, 76 patients, so not an unreasonable experience for a first-in-man study. And I think what you should note here is about 40% of these patients had extramedullary disease. And this is actually the aspect that we're working on with Celgene, looking at these CELMoDs as to whether they've got activity in extramedullary disease. And if we look at the prior treatment in these patients, most of them had seen len and pom. They were IMiD refractory. Most of them had seen bortezomib and kyprolis. A lot of them had seen daratumumab, and about half of them were what we call triple class refractory. So there's PI, IMiD, and CD38 antibody refractory. So to cut a long story short, the results, when they looked at the schedule they're taking forward, 21 out of 28 days with 1 milligram, response rate in this very heavily pretreated population of 50% or so, which is very acceptable for this patient population. And probably what was really exciting was the activity in patients with extramedullary disease. So once they got up to 1 milligram dosage in the escalation, they were seeing responses in nearly all of the patients with extramedullary disease. An example is highlighted here. So I think that these CELMoDs, a bit under the radar in this, era of immune therapies, although you could say they have an immunological mode of activity. But I think really what we've been seeing and what's been seen in this study is a more direct apoptotic inducing activity in myeloma. And I'm looking forward to getting to use some of these in the clinic. So I'll stop there, and I'm very happy to answer any questions. So thank you very much for listening.
Andrew, hopefully you can hear me now. Thank you very much. Yeah, very in-depth, chocker with information in there. I'm trying to keep up myself there. Why don't you just stop sharing your...
Oh, sorry. Yep. Sorry.
So yeah, you go with that one.
Okay.
Yeah. Now, good. So yeah, we'll see if we have any questions, and I can read some of these out. Hey, the first one's from Michael. Andrew, he's asking about your thoughts on CAR T cell therapy. Yeah.
I knew that would be the first question. There's clearly a lot of excitement about CAR Ts, and there's a lot of activity in the myeloma space. There are various constructs being evaluated. We've got a study we've just opened called CARTITUDE-4, which is the legend one, which Janssen now have. And I think if you look at the data from the KARMA study, which was at EHA, that's the BB2121 antibody, you look at the Janssen data, there's a very high initial response rate with these CAR T cells. There's somewhat disappointing durability of response, which the median duration of response is not particularly long. Keeping in mind, however, that these are very heavily pre-treated patients. The other thing that's becoming a challenge is the neurological toxicity, both immediate and delayed. Quite strange delayed toxicity is now being seen in some patients. So what I'm getting at here is I think these hold great promise, but really the appropriately designed trials need to be done demonstrating that they're better than what we have. And the trials asking this question are now opening. So they're being open in patients with less heavily treated disease. And for example, in the CARTITUDE-4 study, it's CAR T versus Darapom-Dex in patients with 1 to 3 prior. So these studies have to be done to define the durability of responses. They also need to be done, I think, to better clarify how to deliver these agents and to manage the toxicity. So I think they're very exciting, but really, I think at the moment, the hype is probably somewhat ahead of the evidence, but those trials are now being opened, thankfully.
I appreciate that. You can probably see the questions coming up here. There's one from Andrew here, something to do with myeloma and myelodysplasia. Seems as though the only treatment is blood transfusions. Any developments in this space? That's a little bit off the...
Yeah, no, I know what you say. We've got some patients like that. And to be frank, no, there's nothing. We've actually treated some of these people with lenalidomide, which sounds maybe paradoxical, but and we've got a man at the moment who we're treating with lenalidomide who does appear to be benefiting both from the perspective of his myeloma and his MDS, but he's got an extremely poor outlook. Not only because of his, transfusional requirements, but also because we can't get him on any trials for his myeloma, because the minute he's got the MDS label, he's, persona non grata. So that's a very challenging space, and I'm sorry, I've got no quick fix for that.
Well, I appreciate you commenting on it. Someone, an anonymous person said, hey, any updates on the myeloma and related disease registry across Australia and New Zealand?
Okay, so in the National Myeloma Workshop that's in a week or so, that's been run by Myeloma Australia as a webinar, which you can all log into. In fact, there is a registry update session. There's an hour set aside for an update on the registry and the APAC expansion of the registry. So I would invite everyone to join that. It's free, and it will give quite a comprehensive update on the registry, the accrual, and the various projects and studies that are being done with the registry. And as I said before, the support from the New Zealand sites is fantastic. They're major contributors.
Sounds pretty exciting. Thanks for, it's really good to know. I'll just, I was trying to take some notes myself. And so it was earlier in the presentation, you just mentioned, you had that, some of the studies about high-risk patients, but you did mention some about LDH marker. Was there any comments with that? You said it was a significant marker? But...
Yeah, look, if you go way back right to the first total therapy trials, and earlier, in fact, the lactate dehydrogenase level has been a powerful marker of adverse disease risk, and it probably is a surrogate for the fact that those patients have got some metabolic changes in their tumor cells which favor drug resistance and the ability to disseminate outside of the marrow. And the shortfall with that myeloma genome project, albeit it was a fantastic body of work, is they didn't have any LDH data. So I think it's a simple blood test, but it's quite powerful. The thing I touched upon with the SCI-92 or EMC-92 platform, that's now been approved by the FDA and in Europe as a diagnostic. And it's very, very standardized, and it's just a one-off test. And we're in the process of trying to get a bit of traction with the funders in Australia to make it available in Australia, but that's, going to be a long road. But I think it's probably the most elegant and validated platform presently available.
Okay, I appreciate that. Yeah, good to know some of these things behind it. We obviously support a lot of patients with myeloma. I've talked with a few, and so I've had this conversation with, well, now we have, obviously in New Zealand, I'm sure you're aware, we have lenalidomide maintenance, coming out of a post-transplant. And so I know some patients, they said, that sounds great. And then I know some will say, I just don't want to take another medication. And I know you showed us some good data, some really good studies there, but what would you comment on that if you were having that conversation with a patient?
Yeah. The concept of a drug holiday is incredibly attractive to patients after they've been, through induction and an autograft. The last thing they want is more drugs and to be trailing back and forth to the hospital. And when we look at the data which informs the reimbursement of LEN in that space, it's a clinical trial. And we know that most clinical trials, when you introduce that therapy into a real world context, you can't recapitulate what the trial has shown. There's a burgeoning body of data in the myeloma space showing that. So the discussions with patients really revolves around, to some degree, their personal circumstances and what you understand about their disease biology. And I think if you've got a good player, paradoxically, they're the people that are going to probably benefit the most from a drug like lenalidomide. So when I have a patient like that, I talk to them about the perceived benefits and say, well, why don't you give it a go? But we're going to have a low threshold here for winding back or stopping if you come along to clinic and say, I'm sick of this. Conversely, if I have people with what I think is adverse biology, I know that probably the lenalidomide isn't going to benefit them in the longer term. But ironically, it's probably important for them to demonstrate resistance to lenalidomide so I can then put them on a trial of new drugs which might help them because of their bad biology. So I just sit down with the patient and talk through the pros and cons in either of those two spaces. And in fact, we've got a study in development using the registry as a platform to look at the deliverability of continuous therapy, lenalidomide, looking at patient-related outcomes and whether the emergence of low-grade toxicities results in, short duration of treatment. Because we can see from the real-world data that the duration of treatment with most drugs in the real world is profoundly shorter than what we see in clinical trials. And we think that's related to toxicity, which is not really being recognized and managed properly. But I do try and get people onto LEN. But, I leave it up to them. I just sit down and explain everything to them.
Appreciate it. That's honest and it's helpful. Yeah. There's another question here, Andrew, I can see in the box. It's, well, thank you very much for your talk, they say. And they admire the myeloma research that has progressed. So for New Zealand patients, they say there's access to only a few simple options: Dex plus one line, thalidomide, bortezomib, lenalidomide. I've used all these lines. Fortunately, Len is still an option for me. The next option, it seems, will be in the private sector. What would be your suggestion, Biljana?
Yeah, I mean, if you could get reimbursed Len, obviously you're going to add something to that. I don't know, the financial resources of people, but certainly adding carfilzomib to Len, the KRD combination, is a highly active combination, and is worth pursuing. And, you can drop down to a more tolerable weekly carfilzomib dosing schedule once a response is achieved. That's certainly an option. I think in a patient with long-standing disease, paradoxically, the longer you've had the disease, probably the more likely you are to respond to another subsequent therapy. And so again, depending on financial resources, DRD, Dara-Revdex would be an active option in this space, exploiting the lenalidomide availability. So I think either of those options, depending on financial resources, is well worth pursuing. The Dara option probably costs more, but it's probably better tolerated.
I appreciate that. And I don't think there's any other questions, but let me just check the maybe in our chat box here. There was something here from the chat box. I'm not sure if you would know this, but any chance the EMP92 screening available in New Zealand? And thanks for the presentation.
Yeah. So this was the SCAR92 platform I was talking about. As I said, we're trying to pursue this, get it onto the what we call MBS, get an item number in Australia, and I suspect that will take a long time because it's not cheap. But if you're looking at it in a holistic fashion, if I could go to the government and say, well, 20% of these patients are not going to derive any benefit from maintenance therapy lenalidomide, they're going to get it for 6 or 7 months, then progress. The cost of that drug, which is not improving their survival, massively outweighs the cost of doing that test. So, pharmacoeconomically, you can show easily that it's a good idea from the dollar perspective. But unfortunately, the regulators and payers don't usually look at things from a big picture perspective. They just look at their own little bucket. So short answer is no, I don't think it's going to be available in New Zealand. I don't think it's going to be available in Australia in the short term, medium term, but it's something we're working on. We can do it, but because we haven't got what's called NATA accreditation for it, we can't really do it for outside centres. But again, we're working on that as well. So you need to watch this space.
Okay, that's interesting insight, Andrew. Yeah, appreciate that. Hey, just one last thing that somebody anonymously texted through. Is there anything, I know there was some, probably earlier on, you commented on, sort of what are the best, what am I trying to say here? Yeah, like ISS and knowing your state. So if somebody, a patient is walking into a hematologist, getting their head around their staging, but you had some comments about, what are some of the best analyses out there? Is there what I'm getting at is there's also genetic mutations. Like, should people be trying to chase up what mutations they have? Because a lot of this might not be readily available, maybe only on clinical trials. What would you sort of advise the average sort of person, walking into the hematologist? Should they be trying to, request these different,
Look, I would, at this stage, in the jurisdictions we work in and treat patients, I don't really think there's any rationale to be pursuing high-tech genomic type characterization of your disease. I think if you can get the appropriate baseline test to attribute your revised ISS score, that can give some insight into the discussions you have with your hematologist. But, in the absence of targeted therapies, which I think are a long way away, if at all, in myeloma, I don't understand why people would be spending money on you know, genomic sequencing based approaches for their disease. You could see in that Myeloma Genome Project paper, you know, there's a vanishingly small proportion of patients that actually had definable high-risk disease with next generation sequencing, about 6%. So I don't see the utility of that at the moment.
Okay. Excellent. I appreciate you answering that as well. So let me just check one last. We might have had one more. Something that popped up. This might be our last one to finish off on. Anonymous. Any treatments that are most likely to adversely affect kidney function?
Well, I think top of the pile there is carfilzomib, well recognized to have renal issues. I've had a number of patients who had quite profound acute renal failure with Kyprolis, which fortunately has been rapidly reversible with cessation of the drug. But there's also a subset of patients who get microangiopathic hemolysis who get renal failure. And I've had a patient die from microangiopathic hemolysis in the context of Kyprolis. So yes, it is recognized as being a problem in a subset of patients in terms of renal dysfunction. Most other things are pretty kidney friendly. You just have to watch out for dose adjustments in drugs like lenalidomide, which of course, you know, can accumulate in the context of renal dysfunction.
Well, that answers that. Thank you so much. And I think at this point, this will probably be our wrap. Really appreciate it. And I just want to say on behalf of, you know, staff at LBC, and there's patients and families we're supporting around the country, I want to say a big, massive thank you, okay? Just for being a part of our webinar, coming on here, joining us from across the Tasman, investing time with us. So thank you, Andrew.
Pleasure. Thank you very much.
Yeah.
Thanks for the invite.
Yeah. And wishing you well with what you get up to for the rest of your day. Okay.
Thanks. Bye-bye.
All righty. Take care. Goodbye to everybody.